Hi everyone, this is Dr. Yvette Batar, your inculcator for this module. And this recorded PowerPoint presentation is all about Introduction to the Cardiovascular System, which is part 1 of the module entitled Drugs Acting on the Cardiovascular System. For our learning objectives, upon completion of this chapter, future nurses will be able to label a diagram of the heart, including all chambers, valves, great vessels, coronary vessels, and the conduction system. Describe the flow of blood using the cardiac cycle, including flow to the cardiac muscle. Outline the conduction system of the heart, correlating the normal ECG pattern with the underlying electrical activity in the heart. Discuss 4 normal controls of blood pressure and describe the capillary fluid shift, including factors that influence the movement of fluid in clinical situations. We go first with the structure and function of the heart. So the heart has 4 chambers, the left and right atrium, and the left and right ventricle. Right atrium receives the oxygenated blood from the circulation, while the right ventricle pumps unoxygenated blood to the pulmonary artery, to the lungs, for gas exchange. Left atrium, on the other hand, receives oxygenated blood via the pulmonary vein, while the left ventricle pumps the blood into the aorta for systemic circulation. Arteries carry oxygenated blood away from the heart, and veins return blood loaded with carbon dioxide and toxins back into the heart. Arteries and veins are linked by microscopic capillaries where there is an exchange of oxygen, carbon dioxide, and metabolites. The heart is the life-giving, ever-beating muscle in our chest. From inside the womb until death, the thump goes on. The heart, for the average human, will contract about 3 billion times, never resting, never stopping to take a break, except for a fraction of a second between beats. So we'll now review the blood flow through the heart that you took up in your anatomy, starting with the left side of the heart. The blood coming from the lungs to the heart collects in the left atrium, filling it up. This initiates a contraction of the walls of the left atrium, forcing the mitral valve to open as the blood gushes into the left ventricle. The left ventricle is then filled with blood, which forces the mitral valve to close and initiates the muscle of the left ventricles to contract, open the aortic valve, and squeeze the blood through the aortic valve and on to the body. The blood coming out of the left ventricle to the aorta is under high pressure. This pressure is enough to rush it into the different parts of the body at high velocity and give its oxygen and nutrients to the body tissues. The blood comes back from the body to the right side of the heart. So we now go into the right side of the heart. The blood coming from the body to the heart collects in the right atrium, filling it up. This initiates a contraction of the walls of the heart atrium, forcing the tricuspid valve to open as the blood gushes to the right ventricle. The right ventricle fills with blood, which forces the tricuspid valve to close and initiates the muscle of the right ventricle to contract, open the pulmonic valve, and squeeze the blood through the pulmonic valve and on to the lungs. The blood will replenish itself with more oxygen and get rid of the carbon dioxide and return to the left side of the heart to begin another cycle. So our cardiac cycle has 2-step process, the systole and the diastole. Systole is the contraction of the ventricles, which is the first heart sound produced by the mitral valve or tricuspid valve which is composed of two leaflets, and the tricuspid valve closing, which is composed of three leaflets. That is why we call it tricuspid. The diastole is the relaxation of the cardiac muscle called cardiac cycle, which is the second heart sound produced by the closure of the aortic and pulmonic or semilunar valves. Third heart sound is produced by the rapid filling of the ventricles in early diastole and is best heard with the bell of the stethoscope. Some diseases are associated with the sound likened to Kentucky, especially those associated with myocardial dysfunction or volume overload conditions. The fourth heart sound is produced by atrial contraction in the late diastole and is always pathologic. It is heard best with the bell of the stethoscope and produces a gallop rhythm likened to Tennessee. This sound is noted in conditions associated with decreased ventricular contraction. So the job of the heart is to pump and get nutrients-rich blood to all areas of the body. The AV valves. So this close tightly when ventricles contract, preventing blood from flowing backward into the aorta, thereby keeping blood moving forward through the pressure. Then the pulmonic and aortic valves. So open with the pressure of ventricular contraction and close tightly during diastole. So these valves operate much like one-way automatic doors. The proper functioning of the cardiac valves is important in maintaining the functioning of the cardiovascular system. We will now move on to cardiac conduction. The conduction system of the heart consists of SA node, atrial bundles, AV node, bundle of His, bundle branches, and the Purkinje fibers. SA node acts as pacemaker of the heart because it acts to stimulate the rest of the cells to depolarize at its rate. Then the atrial bundles conduct impulse through atrial muscles, while the AV node slows impulse and allows delay needed for ventricular filling. So the AV node then sends impulses through the ventricles by way of bundle of His. The bundle of His that enters septum and divides into three branches. So we have now the bundle branches which conduct impulses through ventricles. Then that bundle branches break into a fine network of conducting fibers called the Purkinje fibers, which deliver the impulse to ventricular walls. And our picture there shows the nerve supply that usually going into a specific part of the body. Then the automaticity. This is the property of cardiac cells to generate spontaneous action potentials. All cardiac cells possess some degree of automaticity. Cardiac action potential is a measurement of the membrane potential waveform of the cardiac myocytes, signifying the electrical activity of the cell during the contraction and relaxation of the heart. It has two types, the myocyte and pacemaker potential, and it has 5 phases, and those are phases 0 to 4, which are actually phases of myocyte potential. Phase 0 or upstroke or rapid depolarization occurs when the cell reaches a point of stimulation. At this time, the sodium gates opened along the cell membrane and sodium rushes into the cell, resulting in a positive flow of electrons into the cell, which is an electrical potential. This is called depolarization. Depolarization occurs when the membrane no longer has a positive side or pole and a negative side, or it is electrically the same on both sides. Phase 1, which is early rapid repolarization, is the very short period when the sodium ion concentrations are equal inside and outside the cell. Phase 2 or plateau occurs when the cell membrane becomes less permeable to sodium and calcium slowly enters the cell and potassium begins to leave the cell. The cell membrane is trying to return its resting state, a process called depolarization, which means the return of the polarity on either side of the membrane. Phase 3 is final rapid repolarization. This is a period of rapid repolarization as the gates are closed and potassium rapidly moves out of the cell. Phase 4 or resting membrane potential occurs when the cell comes to rest as the sodium-potassium pump returns the membrane to its previous state. Now with more sodium outside and more potassium inside the cell, spontaneous depolarization begins again. We continue with conductivity, which is the property of cardiac cells. Cardiac conduction or stimulatory is the driving force behind the cardiac cycle. This cycle is the sequence of events that occur when the heart beats, and this cardiac conduction system consists of the SA node, the atrial bundles, the AV node, the bundle of His, and the bundle branches, and the Purkinje fibers. SA node sets the pace for the heart rate because it depolarizes faster than any cells in the heart. However, other cells of the heart are capable of generating an impulse if anything happens to the SA node, which is another protective feature of the heart. When SA sets the pace for the heart rate, the person is said to be in sinus rhythm. AV node is specialized for slow conduction. The significance of this slow conduction is to allow complete filling of the ventricles and to protect the ventricles from abnormal atrial rhythm. Purkinje cells are specialized for rapid conduction. The significance of this fast conduction is to allow contraction of both ventricles at the same time. The autonomic influences. You learn in your anatomy that the autonomic nervous system is a component of the peripheral nervous system that regulates involuntary physiologic processes, including heart rate, blood pressure, respiration, digestion, and sexual arousal. It contains 3 anatomically distinct divisions: the sympathetic, parasympathetic, and enteric. The sympathetic nervous system, or SNS, activates the fight or flight response during a threat or perceived danger, and the parasympathetic nervous system, or PNS, restores the body to a state of calm, while enteric nervous system, or ENS, is an extensive web-like structure that is capable of function independently of the remainder of the nervous system, just like the heart. The heart can generate action potentials on its own and could function without connection to the rest of the body. However, the autonomic nervous system can influence the heart rate and rhythm and the strength of the contraction. So, for the heart, we have the PNS, then cranial nerve or vagus nerve, which slows heart rate and decreases speed of conduction through AV node, allowing the heart to rest and conserve strength, with dominant influence in the SE node, keeping the resting heart rate at 70 to 80 beats per minute. The SNS stimulates heart rate or the heart to beat faster, speed conduction through AV node, and causes heart muscle to contract harder. This is important during exercise or stress when the body needs more oxygen. So the PNS and SNS work together to help the heart meet the body's demands. Drugs that influence either branch can exert autonomic effects on the heart. Okay, we move on with myocardial contraction. Myocardial contractility represents the innate ability of the heart muscle to contract. So for that, we have the sarcomere, which is the basic functioning unit of cardiac muscle, which is made up of two contractile proteins. So for that, we have the actin, which is thin filament. Then the myosin, which is a thick filament with small projections. Then the Z bands, which is the outer edges of sarcomere or the anchor of proteins. Actin and myosin proteins are anchored at these Z bands, which readily react with each other, but at rest, they are kept apart by the protein troponin. So it is troponin that keep protein apart when at rest. So when cardiac muscle is stimulated, calcium enters the cell through channels in the cell membrane and also from storage sites within the cell. This occurs when the cell is starting to depolarize. The calcium reacts with the troponin and inactivates it, allowing actin and myosin proteins to react with each other, forming actomyosin bridges. So these actomyosin bridges is formed by actin and myosin, and this generate active force in muscle. So the actomyosin bridges continue to form as long as there is calcium. So in myocardial contraction, when cell is stimulated, calcium enters cells, which is happening at phase 2, then reacts with troponin and inactivates it, then allows action of myosin to react with each other, forming actomyosin bridges. So note that bridges formed break quickly and myosin slides along to form new bridges. As long as calcium is present, the actomyosin bridges continue to form. The shortening of numerous sarcomeres causes the contraction and pumping action of the heart muscles. The contraction process requires energy and oxygen for the chemical reaction that allows the formation of the actomyosin bridges and calcium to allow the bridge formation. The more calcium present, the more bridges will be formed, which means that the strength of the contraction is determined by the amount of calcium present. The further apart the actin and myosin proteins are before the cell is stimulated, the more bridges will be formed and the stronger the contraction will be. However, if the actin and myosin molecules are stretched too far apart, they will not be able to reach each other to form the actomyosin bridges and no contraction will occur. The electrocardiography and ECG. Electrocardiography is the process of recording the patterns of electrical impulses as they move through the heart, while ECG is a measure of electrical activity of the heart. So as shown in the picture, normal ECG consists of P wave, which denotes atrial contraction, and this is formed as impulses originating in the SE node. The QRS spike is a brief hesitation before the AV node is activated and represents depolarization of the bundle of His, which is the Q, and ventricles, which are the RS. T wave, which are shown as large slow wave in the picture, is caused by ventricular recovery and it represents repolarization. Look into this normal electrocardiogram. An upward pattern indicates a positive voltage, whereas a downward pattern indicates a negative voltage. As shown in the picture, there are 5 waves in the normal ECG, which are P, Q, R, S, T. In addition to that, there are areas that represent critical points on ECG, which includes PR interval, QT interval, and ST segment. PR interval reflects the normal delay of conduction at the AV node, while the QT interval reflects the critical timing of repolarization of the ventricles, and the ST segment reflects the important information about the repolarization of the ventricles. A longer than normal P wave suggests that the atria are hypertrophied and it is taking longer than usual for the electrical conduction to spread over the atria. A lengthened PR interval suggests that there is difficulty in coordination between the SA and AV nodes, like what is seen in first-degree heart block. A heightened R wave indicates that ventricular hypertrophy is present. An R wave that is decreased in height means that the ventricles cannot contract fully, as happens if they are surrounded by fluid, like in cases of pericarditis. Elongation of the T wave occurs in hyperkalemia. Depression of the T wave is associated with anoxia, and depression of ST segment is associated with abnormal calcium levels. We move on into arrhythmia or dysrhythmia, which is defined as a disruption in cardiac rate or rhythm. So this arrhythmia may be caused by various factors, including drugs, acidosis, decreased oxygen levels, changes in electrolytes, and buildup of waste. And this may arise due to changes in automaticity or conductivity of heart cells. And this arrhythmia could also be significant because they interfere with the work of the heart and disrupt cardiac output, affecting every cell in the body. So there are different types of arrhythmias. First, we have is the sinus tachycardia, which is a faster than normal heart rate, usually faster than 100 beats per minute in adult, and it is with normal appearing ECG pattern. If it is too fast, it can lead to decreased cardiac filling time and decreased cardiac output. The sinus tachycardia may be caused by activities like exercise, fear, or stress. So therefore, patient's condition should be determined whether or not it's problematic. Then the sinus bradycardia. This is slower than normal heart rate, usually less than 60 beats per minute with normal appearing ECG pattern. This allows increased time for ventricular and increased cardiac output and often seen in athletes. So usually athletes, they have slower than normal heart rate. Then the supraventricular arrhythmias. So this originate above the ventricles, not in SE node. Featured as abnormally shaped P wave. Show normal QRS complexes because ventricles are still conducting impulses normally. And there are 4 supraventricular arrhythmias. First we have is the premature atrial contraction. So this reflects an ectopic focus or a shift in heart pacemaker from SE node to other side in the atria that is generating impulses out of normal rhythm. So the ectopic foci are abnormal pacemaker sites within the heart, meaning to say it is outside the SE node, okay, that displays automaticity. Then the paroxysmal atrial tachycardia. So this is a rapid heart rate originating in atria, sporadically occurring. We also have the atrial flutter, which is characterized by sawtooth-shaped P wave reflecting a single ectopic focus that is generating irregular, fast atrial depolarization. With atrial flutter, often 1 of every 2 or 1 of every 3 impulses is transmitted to the ventricles. So the person may have a 2:1 or 3:1 ratio of P waves to QRS. Then the atrial fibrillation. So this is with irregular P waves representing many ectopic foci firing in an uncoordinated manner through atria. With atrial fibrillation, so many impulses bombarding the AV node that an unpredictable number of impulses are transmitted to the ventricles. The ventricles are then stimulated to beat in fast, irregular, and often inefficient manner. Furthermore, for our arrhythmia, we have atrioventricular block or heart block. So this reflects a slowing or lack of conduction at AV node, may be due to structural damage, hypoxia, or heart muscle injury. And our heart block could be first, second, or third degree. So in first degree heart block, all from SE node arrive in ventricles but after a long, the normal period, characterized by lengthening of the PR interval beyond normal, and its P wave is followed by a QRS complex. Second degree heart block is when some impulses are lost and do not get through, resulting in slow rate of ventricular contraction. QRS may follow 1, 2, 3, or 4 P waves. Then, in third degree heart block or complete heart block, there is no impulses from SE node that gets through the ventricles, and there is much slower ventricular automaticity that takes over. Waveform shows total disassociation of P wave from QRS complexes and T waves. Because P wave can come at any time, PR interval is not constant. QRS complexes appear at very slow rate and may not be sufficient to meet body's need. Lastly, we have the ventricular arrhythmias. So these are abnormal heartbeats that originate below the AV node. So lower heart chambers called ventricles. and QRS complexes appear wide and prolonged, and T waves are inverted, reflecting slower conduction across cardiac tissues. So there's arrhythmias or ventricular arrhythmias, as mentioned, are abnormal heart rhythms that make the lower chambers of the heart twitch instead of pump. So this can limit or stop the heart from supplying blood to the body. While some of these arrhythmias are harmless and don't cause symptoms, some can have serious or even deadly effects on the body. So these types of arrhythmias cause the heart to beat too fast, which prevents oxygen-rich blood from circulating to the brain and body and may result in cardiac arrest. Then, the premature ventricular contractions or PVCs. So this can arise from a single ectopic focus in the ventricles, with all of them having the same shape QR, and this arises from many specific foci which produces different shapes. Runs or bursts of PVCs reflects extensive damage or hypoxia in myocardium. Then, we have ventricular fibrillation, which is seen as bizarre, irregular, distorted wave. Fatal because it reflects lack of any stimulation of ventricles, resulting in no blood being pumped to the body or brain. Thus, there is total loss of cardiac output. So here are figures or pictures for you to see how these different arrhythmias looks like in an ECG. Just take a close look on them when you grab your copy of PLP. So you have there more ECG pictures. We will now proceed to circulation. So there are two types of circulation, the pulmonary and systemic circulation. Pulmonary circulation is in the right side of the heart that sends blood to the lungs where carbon dioxide and some waste products are removed from blood and oxygen is picked up by the RBC. Systemic circulation, on the other hand, is in the left side of the heart that sends oxygenated blood out to all of the cells in the body. So, in the systemic circulation, the heart pumps blood from the left ventricle to the aorta into the general circulation, and then blood is carried by the arteries to the arterioles down to the capillary beds where nutrients in the blood are exchanged with waste products at the cellular level. Blood then returns through the venules to the vein back to the heart. Okay, I would just like to make mention also that in the pulmonary circulation, when the heart pumps the oxygenated blood that contains carbon dioxide from the right ventricle through the pulmonary arteries to the lungs, oxygenated blood returns to the left atrium by the pulmonary vein. The coronary circulation. The muscles of the heart or myocardium requires constant supply of oxygenated blood to keep contracting. It receives blood from two main coronary arteries that branch off the base of the aorta from an area called the sinuses of Valsalva. These arteries encircles the heart in a pattern resembling a crown, which is why they are called coronary arteries. The left coronary artery arises from the left side of the aorta and bifurcates or divides into two large vessels called left circumflex artery and left anterior descending coronary artery. So the coronary arteries receive blood during diastole, meaning to say at rest, and the heart circulation pattern is called end artery circulation. So the left coronary artery feeds the septum and anterior areas, including much of the conduction system, while the right coronary artery supplies most of the right side of the heart, including the SA node. The pulse pressure. So this is systolic pressure minus the diastolic pressure. And this pulse pressure is the pressure that fills coronary artery. And this is the difference between systolic pressure or the ejection pressure and diastolic or resting pressure. And this is monitored in order to evaluate filling pressure of coronary arteries. So main forces that determine oxygen consumption, we have the heart rate. So the more pumping, the more oxygen requirement. The preload, which is the amount of blood brought back to the heart to be pumped throughout the body. The more blood returned, the harder the heart will work. Blood volume is determinant of preload. Then the afterload. So this is resistance against which the heart has to beat. The higher is the resistance in the system, the harder the heart will have to contract to force open the valves and pump blood. So the blood pressure is the measure of afterload. Then the stretch on ventricles. If ventricular muscle is stretched before it is stimulated to contract, more actomyosin bridges will be formed. If stimulated harder than usual, which happens with sympathetic stimulation, more bridges will be formed. More bridges formed means more energy required. So, the preload is basically stretch. So, it's the volume of blood received by heart, while the afterload is the squeeze. So, this is the pressure or resistance the heart has to overcome to eject blood. We move on into systemic arterial pressure, which is the contraction of the left ventricle that is greatest during systole and lowest during diastole. So there are conditions, enzymes, and peptides that affect the systemic arterial pressure, and these are the hypotension, hypertension, vasomotor tone, renin-angiotensin-aldosterone system, and natriuretic peptides. Hypotension is a low BP from loss of blood volume or from failure of the heart muscle to pump effectively. If severe, can progress to shock and even death as cells are cut off from their oxygen supply. Hypertension is a constant excessive high blood pressure that can damage fragile inner lining of blood vessels and cause disruption of blood flow to tissues. This puts tremendous strain on heart muscle, increasing myocardial oxygen consumption and puts heart muscle at risk. Can be caused by neurostimulation of blood vessels that cause constriction, thus raising BP, increased volume in the system, and unknown cause in most of the cases. Drugs given for hypertension are aimed to changing one or more of normal reflexes that control vascular resistance of force of cardiac muscle contraction. Vasomotor tone refers to degree of constriction experienced by a blood vessel relative to its maximally dilated state, an essential determinant of BP, and these impulses work to dilate vessels if more blood is needed in an area, constrict vessels if increased pressure is needed in the system, and maintain muscle tone so that vessels remain patent and responsive. Vasomotor tone are impulses coordination that is regulated through medulla in an area called cardiovascular center. If increased pressure is needed, cardiocenter increases sympathetic flow to vessels, and if pressure rises too high, sympathetic flow is decreased. The renin-angiotensin-aldosterone system is another BP determinant. It increases BP. Natriuretic peptides are formed in the atria of the heart and in the brain. It's called atrial natriuretic peptides when it's in the heart, and it's called brain natriuretic peptides when it is in the brain. We also have other natriuretic peptides, which are the CNPs and the DNPs. CNPs, or the C-type natriuretic peptides, which is thought to act in the vasculator, and the DNPs, or the dendroaspis natriuretic peptides, which are thought to be released from the atria. So the natriuretic peptides act to inhibit the renin-angiotensin-aldosterone system and cause a diuretic, natriuretic, and BP lowering effect. ENP and BNP are released in response to high ventricular filling, like for instance, a fluid overload or failure of heart muscle to perform its function is occurring. The levels of peptides are linked to heart failure. Kindly take a look into the figure reflected in this slide and follow the numbering as I elucidate them. So enzymes renin is activated by decreased kidney blood flow, which also decreases oxygenation. This may occur in cases like mentioned in number 1, dehydration, sodium deficiency, or hemorrhage. The decrease in blood volume will then result to decrease in blood pressure, which will activate the juxtaglomerular cells of the kidney to release or increase the enzyme renin. The renin in number 6 will then be transported to the liver, converting angiotensinogen, a protein produced in the liver, to angiotensin 1, which is a hormone that raises BP in response to signals from the kidneys, thereby increasing angiotensin 1, and this angiotensin 1 will then travel to the lungs where it is converted by angiotensin converting enzyme, or ACE, to angiotensin 2, thereby increasing the angiotensin 2. This angiotensin 2 will now travel through the body and reacts with angiotensin 2 receptor sites on blood vessels, causing vasoconstriction as shown in number 15, thus increasing the BP as shown in number 14, and blood flow to the kidneys, which decreases renin when BP returns to normal, since renin will only be activated by low blood flow or BP. Angiotensin 2 in number 10 will then stimulate the secretion of aldosterone that is produced by the zona glomerulosa of the adrenal cortex, as reflected in number 10, thus increasing aldosterone as shown in number 11. Aldosterone is involved in the retention of sodium in the kidney and other glands, likewise with the retention of water or reabsorption of sodium and water, as shown in number 12. The increase in sodium and water reabsorption leads to increased blood volume, and thus increasing the blood pressure. The increase in angiotensin 2 mentioned in number 9 that causes vasoconstriction go to the arterioles, which also increases the BP. We will now continue with venous pressure and heart failure. Venous pressure is pressure in the veins that may sometimes rise above normal. Rise can happen if heart is not pumping effectively or unable to pump out all blood that is trying to return to it. Inability to pump out all blood results in backup or congestion of blood. We call that venous congestion. Heart failure is failure of heart muscle to do its job, which is to pump effectively. That rise in the venous pressure we mentioned a while ago from blood back up increases the HP or the hydrostatic pressure, or sometimes called fluid pressure, on venous end of capillaries. Higher HP than OP or osmotic pressure will cause fluid to be lost into the tissues, which accounts for edema in heart failure. So, actually this HP pushes fluid into the capillary, while the OP pulls fluid into the capillary. So again, HP pushes fluids while the OP pulls fluid into the capillary. Pulmonary edema results when left side of the heart fails. Peripheral, abdominal, and liver edema occur when the right side of the heart fails. We also have other factors that contribute fluid loss in tissues. And for that, we have protein loss and fluid retention. Protein loss can lead to fall in osmotic pressure or OP and inability to pull fluid back into the vascular system. This is noted in renal failure when protein is lost in the urine. And this is also seen in liver failure when liver is no longer able to produce plasma proteins. For fluid retention, often this is stimulated by aldosterone and ADH or antidiuretic hormone as mentioned previously. So this can increase HP so much that fluid is pushed out under higher pressure and the balancing pressure to pull it back into the vessel is not sufficient. So drugs that are used to treat heart failure may affect the vascular system at any of these areas in an attempt to return balance to the pressures in the system. And that is the end for this chapter. Thank you for your attention.